Hi, I'm Dr. Alan Brown, President of the National Lipid Association. Thank you for joining us today. We're broadcasting live from the American Heart Association sessions in Chicago, Illinois. Today I have the privilege of talking with Dr. Carl Orringer, who's a past president of the National Lipid Association and who is also one of the authors of the new AHA-ACC 2018 cholesterol guidelines. He was the National Lipid Association representative to the Guideline group. We'll also take some time to talk with Dr. Peter Jones, who's Associate Professor of Medicine at Baylor University and the Chief Science Officer for the National Lipid Association, to get their insights on the new guidelines. 2013 recommendations were a start with the 4 statin benefit groups and the fact that we could identify those people who clearly got benefit from statins. How do you see the couple of documents that have come since from the NLA and the ACC expert consensus documents? How do you see the metamorphosis from 2013 to now, and what are the most important things that were added to the new guideline that bridge that gap?
Well, I think that there were a number of things that enabled us to make new recommendations in this 2018 guideline. First of all, there was new research, especially other agents that increase the expression of LDL receptors made a big difference. So the IMPROVE trial with ezetimibe made a big difference in that there was effective additional risk reduction with the addition of ezetimibe to a moderate intensity statin. And then the PCSK9 inhibitor trials, which also showed that with very marked LDL cholesterol reduction, once again by upregulating the expression of LDL receptors, we had further reduction in LDL cholesterol and further benefits. So we now see a hierarchy of benefits that are being seen as you further lower LDL cholesterol. So a position that the NLA had even prior to the 2013 guideline of the ACC and AHA was lower LDL cholesterol is better, and the data that we've seen in the last 5 years have actually supported that position.
So along that line, just taking it a step further, there was sort of a resistance to set quote goals on the 2013 recommendations because of the wide display in baseline lipid levels. Now we have a threshold, which at least gives us some guidance for adding those non-statin therapies. How did you come to a consensus on the concept of threshold? And could you give us 1 minute on how you define threshold versus goals?
Well, okay, so a couple of terms. Targets is the specific lipoprotein number that one goes for. Goal seems to be numbers below that target when you see additional benefit in terms of ASCVD risk reduction. The reason that the term thresholds were used is because it is felt that it's probably not an absolute number, but it gives you one additional piece of information that you can use. Say if you don't get 50% reduction in LDL cholesterol from a high-intensity statin, you now have a number that you can use, 100 in primary prevention and 70 in secondary prevention, to now say there is something that we can shoot for that seems to be associated with the benefit that was seen in randomized controlled trials.
So that's really a number above which you would add additional therapy.
Correct.
Rather than a number you're trying to hit.
Correct.
It's a trigger, right, to add additional therapy.
It's one additional factor that one can use in making that decision.
I noticed that you added some enhanced risk factors, some things that would make you more concerned about a patient and maybe be more aggressive with therapy that in the past there hasn't been much discussion about, which would include Lp(a), ApoB levels in people with high triglycerides, and calcium scoring. I thought that was intriguing. It's something that clinically a lot of people do, but here there was clear guidance about that. So I wonder if you could speak a little bit to how you got to that, and then maybe a point on Lp(a) and in whom one has to worry about it.
So there's a whole list of risk-enhancing factors that would help clinicians to decide whether they were going to recommend the addition or the initiation of statin therapy. And these are factors that you use as part of the risk discussion. I loved the use of the risk-enhancing factors because it really brings the clinician back into play. The clinician then can discuss this with the patient, saying, you have several of these factors, and now maybe this is not perfectly randomized controlled trial based, but you have enough of these factors to suggest that you would likely benefit from taking a statin. So let's talk about why that benefit makes sense in your case. So the risk-enhancing factors actually enhance the clinician-patient discussion. Specifically with regard to the issue on Lp(a), again, we're in that gray zone where it's not 100% evidence-based, but it's pretty clear that those patients who have Lp(a)s, either 50 milligrams per deciliter or higher, or 125 nanomoles per liter or higher, those patients seem to be at increased risk both for ASCVD and for progressive aortic stenosis. So again, it's not the hardest, not the most evidence-based approach, but clinically, we know as clinicians that it makes a difference, and so it helps us in providing more clinically based but appropriate recommendations for our patients.
I noticed they called out a difference in Lp(a) as a risk factor for men versus women for primary prevention. I wonder if you could comment on
So
that.
there was a study suggesting that whereas Lp(a) elevation seems to really be associated with increased cardiovascular risk in men, it does not seem to be associated with cardiovascular risk in women who have normal LDL cholesterol levels. So thus far, certainly the guideline did not differentiate between those two groups, but this is one of the places where the NLA can further lend its expertise, and in fact the NLA is currently involved in a position paper on Lp(a), and I think we will hopefully be able to even tease out more of that information as the paper comes out.
And now I have the pleasure of talking with Peter Jones, who's Associate Professor of Medicine at Baylor. He is our Chief Science Officer at the National Lipid Association. So Peter, we had the fun of sitting through the guideline presentation this morning. I think we were all excited about what was presented. What stuck out in your mind as sort of defining moments today?
Well, I think the important thing for our membership is the focus on primary prevention, number one, and the focus on FH. Now, when I talk about primary prevention, I'm talking about people with diabetes but no atherosclerotic cardiovascular disease, or people without diabetes and no cardiovascular disease, being pushed forward as in the patient-provider discussion to decide, using these risk enhancers as you've discussed with Carl, to help make that decision about should I take a statin or not. And I think that was a very important part of it. It's like what we did in our recommendations, where we got back to the provider and the patient talking about individual characteristics of a person that makes them uniquely at high risk. Not a risk calculator necessarily, but these risk enhancers. And we had that. And these risk enhancers included things we've talked about in our recommendations, which included women with histories of preeclampsia, gestational diabetes, putting them at higher risk if they've had that in their history. Chronic inflammatory disorders like lupus, psoriatic arthritis, RA, HIV, and certain ethnic groups like South Asians. These are all risk enhancers. They were part of our recommendations. I'm glad to see that they're now part of the discussion.
Yeah, and the renal insufficiency. For some reason, we had a hard time getting that in, so it's nice to see that.
CKD, it's in there as well. So I encourage everybody to go take a look at the risk enhancers, because I think it really is an important part of helping make decisions in primary prevention. What I did like about the patients with FH was that they suggest, starting at age 20, that we don't have to use a risk calculator. We need to talk about long-term statin treatment. No risk calculators.
Right.
And I think that gets primary care involved, because they see some of these young people with LDLs at 250 and they go, oh, you're too young, you don't need to be on therapy. No, you need to be talking about what their long-term therapy is, and I think that was wonderful. I also think the concept of diabetics without cardiovascular disease, they also do not need to go through the risk calculation. They're high risk. And a discussion needs to be started with at least moderate intensity statin. And if they're higher risk diabetics, a little older, then high intensity statin needs to be considered. And they finally added, what do we do with diabetics under the age of 40? Between 20 and 40, now they say you can consider statin treatment important in that group if they have long-standing diabetes and evidence of microvascular disease. I think that's huge. They clarify how we talk to these patients earlier in life about strategies for risk reduction using statins.
Yeah, and I thought it was very valuable to talk about pediatric treatment as well as women who are postmenopausal or had premature menopause from surgery, for example.
Correct.
So I really thought that those special populations were looked at very thoughtfully.
They were.
And starting statins on FH children at age 10 was a big step forward, I
Yes,
thought.
it was. I
And it
agree.
gives guidance to what struck me was that what was described in the guidelines are things that preventative doctors generally do. They look at all the risk factors, they try to make an assessment of individual risk. And I thought the calcium score addition to the whole discussion really did start to hone in on individual risk versus a global risk score. I don't know what you think.
I absolutely agree. I think they specifically stated if, after looking at risk enhancers, and if you need further help with your discussion in the patient and primary prevention, to do a coordinated calcium score. And they talked about both positive calcium being an important reason to move forward with recommending statin, and then the power of zero. If you have a coordinated calcium of 0, you can discuss about continuing with just lifestyle and important preventative features there, and maybe not taking that step towards a statin.